So I've been asked to talk about this because I think it's an important topic. Before I talk about why I think it's important, I just need to let you know that I have relatively limited experience with extraction of conduction system type leads. But despite that, I'm relatively optimistic that extraction probably isn't going to be that different. Now, we've already heard from earlier speakers about the change in the way we've thought about our pacemaker technology, the indications, how we might apply these current leads, culminating in various guidelines discussed by earlier speakers. And these are very important. Clearly, there's a lot of excitation, a lot of widespread adoption of the ideas of CSP. As you can see from the recent APHRS meeting, many abstracts and presentations on conduction system pacing, just like our earlier presentations. Well, that's all very well and good, but there's no point doing that if we're not going to think about the other things, and that is mechanical lead problems and good surgical technique to avoid infections and hematomas. And of course, we want our patients to do well. We want them to come back and need replacement generators. But every time they have a procedure, there's a risk of an infection. And if you've implanted a conduction system pacing system, we might need to think not just about the acute procedure, but about what's going to happen in 10 years' time, 20 years' time. Now, most in the audience will be familiar with the idea of lead extraction. As you can see from this animal model, that lead extraction is designed to try and control the force to remove the leads. And what you can see in this cartoon over here is the issue when you just pull on the lead, you can deform the ventricle, as you can see here. So lead extraction tools have been developed to try and minimize those forces, and most of you will be aware of the fact that there are rotational tools as part of the tool kit. Now that's all well and good when we're dealing with this situation, again an animal model. Oops, beg your pardon. As you can see here, this is a endocardial lead fixed into the right ventricular wall. You can see the removal of the lead from the tissue, and notice the deformation of the right ventricle. Okay? Why are my slides? There we are. And obviously, our traditional endocardial lead placement means the tip is abutting the endocardium, pacing locations. And as you can see on the bottom right here, there are certain points on the lead that are subject to more force, and that has relevance when it comes to lead extraction and to understanding why leads fail. And going along with that, we've also got a reasonable understanding of some of the forces that the leads and the vascular structures are subjected to, particularly the SVC and the ventricle. And that's helpful when you're removing leads such as, in this case, report of removing 3830 leads from a now adult who underwent pacemaker implantation as a child. We can understand how those leads might behave. And because of the use of the 3830 for 20 years, we've now got some useful information to guide us about how lead extraction might need to occur. The trouble is that most of the case reports or series refer to lead removal, not lead extraction. So for example, in this paper, all of the cases had their leads removed by manual traction alone, not needing device tools. So I don't think it's going to be the same though for conduction system pacing. And the reason why I don't think it's the same is, as you can see in this image here, there's my mouse, here it is, you can see the tip of the lead perforating into the left ventricular cavity. And you can see through the cutaway in this gross anatomical specimen just quite where the tip of the lead distal electrode might be, but also where the proximal electrode is. And that means a whole bunch of things that might be very different in terms of how fibrosis occurs, the fact that leads don't necessarily have steroids along the length of the electrodes. There's a lot of uncertainty and unknowns. Now, because of where we're placing these leads, we need to think about lead design. And clearly, there's only one lead on the market that's been approved for and used consistently, but many of us use stylet-driven leads as well. And this has taught us some lessons. So, for example, in this 2-patient report from a Belgium group, where they have fractured the screw at the time of implant and been unable to retrieve the entire lead. They've left a screw behind, as you can see on the CT. And here, with another one of their cases, during the acute implantation, they could not remove the lead and have had to abandon it. So not all leads are the same. We're asking a lot, as you can see, with some of these ideas here. Now, it's perhaps better seen in this ventriculogram and study where we can see our CSP lead compared to the right ventricular lead, just in terms of the difference in movement and the potential mechanical forces that might be placed on those leads because of their different positions. And it's been helpful to think more about the sorts of forces that they might undergo from some of the work that's been done here in Beijing. So, for example, here from CT data of patients who have undergone CS pacing, colleagues have used some finite element modeling to actually look at, for example, the difference between lead position and systole and diastole, and then create a number of variables to assess the types of forces that the leads might be subjected to guide us in thinking about how we might expect these leads to behave mechanically and electrically, but also how they might behave when we need to extract them. And in their study, they highlighted the fact that for the 3830, there was much greater variation in the movements seen just proximal to the proximal electrode. Fortunately, in these simulations with the 3830 lead up to 400 million cardiac cycles, there was no exposure of extra problems with the lead, but we don't know what that means for other lead designs. So how does the 3830 behave? Well, we know from some quite elegant work done by the Americans, where they have built lead models, they've simulated binding sites, as you can see over here, and then subjected the 3830 to a variety of stressors to understand the properties of the lead. And it's quite interesting, when they've done that, they've been able to generate some interesting information about the tensile properties of the lead, as you can see over here, where the inner cable might fracture, where the insulation might fail, and where the coil might fail. And going along with that, there's this clue about just what might happen to the lead when extreme force is placed. This is New Zealand's most experienced conduction system pacing implanter, Matt O'Connor, that you mentioned before in your presentation. And he's on the chair, and this is a 3830 lead. Oh. I do apologize. So hopefully my colleagues will be able to sort out why the slide's advancing. Okay. They worked really well yesterday at the IT bench. Well, while we're waiting, how many people here have removed a CSP lead? The slides aren't moving. They're moving on my screen, but they're not moving on the projector for some reason. Okay. Okay, that's a good suggestion. Let's see if that works. It's not advancing now. Yeah. Right. So here we go. So sorry about that. It was working perfectly on my screen. So we can see here the X-ray images of the septal lead, conduction system lead versus a traditional RV lead. And you can see how those forces might play differently on those positions, particularly with the proximal coil deeply embedded in the septum. And from the learnings thinking about those leads, the Beijing group have published work where they've simulated the lead forces based on real patient data sets. And I mentioned before about the systole and diastole images, them being incorporated into a finite element model and using that to help think about some of those forces as they are shown here in various positions. And as you can see here, the majority of the movements, the maximum movements of these leads occurring just near to the septum, just behind the proximal electrode. Now, despite their concerns about how the leads might perform, the leads have actually performed very well mechanically and electrically with relatively short-term follow-up. And as I was mentioning before, the American group have done a variety of things to assess how, in particular, the 3830 lead might perform when it comes to extraction. And as you can see on this rig here, they've got simulated binding sites, and they've, in a standardized way, subjected the lead to a variety of different stressors. And through this, they've been able to give us some insights as to how the 3830 lead might progress and how it might fail. And as you can see on the side here, the different components of the lead failing at different times. And with that, you can see this 3830 lead here being disrupted quite significantly. Now, not all is lost if you do this to the lead, and hopefully this will play this time. This is Matt O'Connor, and he's sitting on the chair, and I've got a 3830 lead in his hands, and you can see the leads start to fail in various parts. But there's still sufficient tensile strength to drag him across the lab. Okay, so these leads might be more interesting in terms of how they behave, but we don't actually know what happens later on. We don't have much experience. What is published is often small case series or case reports. And for example, this Polish group, a small number of patients, 9 patients, the majority of their patients not requiring formal extraction tools. Some of the prolific authors also reporting their experience with lead removal or extraction, and a Japanese group doing the same. All of them reporting that this is technically possible without perhaps some of the concerns that might be raised about damage during extraction. That's not really helpful if the dwell time of these leads is only for a few years. And this is an interesting report from Migliori in Italy, where he reported a lead that had a dwell time of nearly 14 years, And notice that his report talked very much about the lead adhesions seen in the proximal tree with considerable fibrosis, but still with successful extraction. He's then gone on to report a larger series, and it's quite interesting to see the range of ages seen here between very young patients and the dwell times, but still reporting success, but a greater need for the use of extraction tools than perhaps the earlier experience with shorter dwell times. Now, obviously, the experience grows, and Dr. Vijay Raman and others have published on, again, increasingly large series, and noting that the longer the dwell time, the more likely there is to need an extraction tool. And here are some images for some of the fibrosis that can occur around the lead tip and around the body of the electrodes. So what does this all mean to the extractor? Well, most of us are well aware of the concerns about the tricuspid valve with traditional pacing. There's increasing concerns that we may be causing more tricuspid valve damage. And when it comes to conduction system pacing, I think we need to think quite carefully about how we implant and what the impact might be when we come to extract. And we can see from this particular study, again from Beijing, assessing the degree of tricuspid regurgitation. It may be more common than we've anticipated. And it's clear that there are some important parameters that we can use to guide us thinking about protecting that tricuspid valve. Work done talking about the distance down the septum that the leads might need to be implanted into. And if you have a look at these images from Yeng Ho and Matt O'Connor, you can see the proximity of the septal leaflet with the catheter and the lead here coming much more towards the tricuspid annulus. And this is why it's so important that we actually do perform ventriculograms to see where the valve annulus might be, so we can try and avoid damaging the tricuspid valve at the time of implant. Now, it's very important that we consider the tricuspid valve, because the EHRA document, for example, focuses much more heavily on the concerns about perforation into the ventricle. But I draw your attention to this point up here about entanglement of the trabeculae and possibly of the septal leaflet or caudal apparatus. And that's important when you think about the extraction issues. Most of us who have done some CSP have seen when we don't get good parameters and we remove the lead, we can find material trapped in the coil. But is it myocardium? Is it caudal apparatus? We don't know. And if we don't know, we can possibly get into this situation where leads cause tricuspid fibrosis and dysfunction and cannot be extracted safely by percutaneous methods. Now, the other issue is to do with the fact that those of us who are in the extraction area know that we are often dealing with more than one lead that needs to be extracted, especially with infection. And there are some issues about how we might think about extraction for CSP. There's differences in the thinking about how you might prepare for this. And the order in which you extract the CSP lead may have some bearing. And we'll talk a little bit more about that in a moment. But you can imagine when you are trying to remove a lead, most people focus on a superior access, but there are times when you might need to consider the femoral access. And in this example, a case report removing a lead that's only 4 months old, the lead has fractured, and that's not supported the ability to put a locking stilet down. So they've used a femoral snare. This is one of my cases where, goodness me, why is this mouse not moving? There we are. that I've found significant binding in the proximal tree, and I've used a femoral approach to extract the ventricular lead without any difficulty. Now, it's important to think about the extraction approach because often we're thinking about reimplantation for non-infective indications, and we need to think about what the septum might look like 10 years' time in terms of scarring and fibrosis. And here's something I think most of you will have seen before, just reinforcing the point that there are multiple leads to think about, and particularly in this example where there is an implant from the right, which can be more technically challenging, a defib lead, a left ventricular traditional CRT lead, as well as a conduction system lead. There are different approaches that would be useful when trying to extract this. And again, the tandem approach is often very helpful. Larry Epstein, who would be known to many of you, talks a lot about lead-on-lead crime, where leads abrade each other, and there are many case reports about this. Conduction system pacing also has the same problem, and for example, in this case report, there was lead dysfunction because of the defib lead interaction with the conduction system pacing lead. So there's not only lead-on-lead issues, but there's lead-on-tool and tool-on-lead issues that we as extraction people need to think about, because it has a bearing on our tool selection. And this is why. This is the fibrous tissue that can be accumulated with longer dwell time leads. So we need to plan the tools that we use. And you can see on this image a 3830 lead inside an Evolution RL extraction tool. There seems to be a significant disparity between the lead size and the tool. But that's actually useful because it helps you overcome the amount of fibrous tissue that is seen without jamming the lead and fibrous tissue into a too small a sheath. So I still use an 11 French RL for all of my 3830s. And the reason why isn't so much probably where the lead is fixed into the septum, but even from 10 years ago, the warnings about the amount of proximal binding in the SVC brachiocephalic is as important as the binding in the heart. And this binding is very important. This is the same patient I showed before who's had their ventricular lead now extracted, but there's still binding along the course of that lead that's requiring an extraction tool. And if you look on this panel here, there's a manual removal of the 3830 lead, but just watch what happens to that atrial lead and the central venous catheter. See how much that moves with that lead-on-lead binding. So we need to think about that in terms of planning our extraction. I think it's really helpful to be reminded that we are focusing on the acute implant and the early part of our learning phase with conduction system pacing. But you need to think about what's going to happen in 10, 20 years' time. And again, from this particular paper I mentioned earlier, they have offered some practical advice, and it's to do with the preparation of the lead. Now, I'm not going to go into the details of this because I actually do not support their technique. And the reason why I don't support their technique of removing the IS-1 pin is that we've learnt lessons from leads like the fine line and Ingevity that removing the IS-1 pin may make the tensile strength of the lead less. And coming back to the, and as an example, there's a non-3830 lead where different considerations need to be taken. So this is the Cook Medical advice on how to use their tools for a standard lead. This is the work that Bruce Wilkoff and Piers Vatterott I showed earlier on in terms of the lead forces. This is their complex way of trying to prepare the lead to put a rail on to allow them to use an extraction tool. Well, it looks really complex. I'm quite lazy. This is what I do. You can see on the left panel here, there's where's my mouse? Here it is. We can see a 1 tie, and we can see the IS1 pin attached. There's the bulldog being placed over the lead. Now that's not a good place to park it because, as you can see on this next image here, there's extra bulk with the mandrel and the IS1 pin. So I take the mandrel and the binding point well down the lead before I fix it so there isn't the same bunching. Much easier, saves time, you don't need to cut things. So, my final thoughts about extraction for conduction system pacing. I think we are gaining more experience, but it is still limited, and we still do not know how these leads are going to behave later on. I think we still should be optimistic that these are not going to be a big problem if we think about how to extract and how we implant. There are considerable uncertainties about what future lead designs might bring to CSP work in terms of different iterations, steroid application, screw length, various other factors. And we don't have experience to understand what might happen, for example, with tricuspid valve damage or with potential tunnels or fibrosis within the septum for these very long dwell times. Extraction certainly requires planning, but I'd plead with you to think about when you implant these leads, what it's going to be like for the future extractor. And we've obviously got to learn and share our experiences, both good and bad, so we can understand things better. People always ask, do we need new tools, different tools? Possibly, but at the moment the tools we've got, if they're used well, can be quite rewarding, quite safe and successful. So I think conduction system pacing, there's some gems there, there's some gold, there's some excitement about what this might bring for us, but please, please think about what might happen in the future, because there may be some danger there. We just don't know. Thank you.